cultural, linguistic, and educational backgrounds. It has been designed to be very simple and it is a multilingual tool. Or even if it is not available in a multilingual fashion, you can use a translator to get through to your patient. The CRT6 was designed to be easy to use and was written in a style intended for a general audience with no clinical training. Generally, laymen will use a CRT and medical personnel will use a SCAT. So how does it look like? So when you look at the CRT6, first thing you will see is something called a red flag or call an ambulance. If any of the following signs are observed or complaints are reported after an impact to the head or body, the athlete should be immediately removed from play game activity and transported for urgent medical care by a healthcare professional. What are the signs? Neck pain or tenderness, seizure, fits or convulsion, loss of vision or double vision, loss of consciousness, increasing confusion or deteriorating conscious state. That means he is becoming less responsive and more drowsy. Weakness or numbness or tingling in more than one arm or leg. Vomiting or repeated vomiting. Severe or increasing headache. Increasingly restless, agitated or combative. Visible deformity of the skull. If you see any of these signs when you are administering the CRT, make sure you call an ambulance and transport the patient to a hospital. Next, you will look for visible clues of suspected conclusion. They are loss of consciousness or responsiveness, lying motionless on the playing surface, falling unprotected to the playing surface, disorientation, confusion, staring or limited responsiveness, or an inability to respond appropriately to questions. Dazed, blank or vacant look. Dazed, blank or vacant look. Seizure, fits or convulsions. Slow to get up after a direct hit or indirect hit to the head. Unsteady on feet, balance problems or falling over, poor coordination and wobbly gait. Any facial injuries. If you find any of these, you can be sure that the person has got a concussion. Step 2, symptoms. Look for these symptoms. Physical symptoms like headache, pressure in the head, balance problems, nausea, vomiting, drowsiness, dizziness, blurred vision, more sensitivity to light, more sensitivity to noise, fatigue or low energy, don't feel right in any manner, neck pain, change in emotions such as more emotional, more irritable, sadness, nervous or anxious, changes in thinking like difficulty concentrating, difficulty remembering things, feeling slowed down, feeling in a fog. Please remember, symptoms may develop over minutes or hours following a head injury. Step 3, awareness. You can modify each question appropriately for each sport and age of the athlete. If the athlete is unable to answer any of these questions correctly, it may suggest there is a concussion. Where are we today? What event were you doing? Who scored last in this game? What team did you play last game? Did your team win the last game? So you have to tailor-make your questions from immediate to a bit more recent past. Okay, so you have done all the CRT steps and the athlete is not shown any positive signs or symptoms. But you still suspect that the athlete has got a concussion or there is a strong suspicion by you or by the medical team. In that case, you may do something called exertional provocative tests. 5 push-ups, 5 sit-ups, 5 knee bends, and if any of these symptoms are positive, then don't do the sprint. But if they are not positive, then do the 40-meter sprint. Some athletes who are at rest and they are asymptomatic at rest, even with a concussion, if you do this test, they will get headache, unsteadiness, and cognitive dysfunction after the physical exertion. Why does this happen? When you do exercise, cerebral blood flow increases, systemic blood pressure increases, and that is why these symptoms will develop when the patient does exercise. So let's talk about return to play. The most important criteria for safe RTP is complete return of normal brain function as assessed by examination. No RTP till cognitive function is normal and all symptoms, headache, unsteadiness, cognitive dysfunction, and at rest and after exertion are gone. Only then will return to play be even considered. After a grade 1 concussion, a player can return to the contest if after 15 minutes he or she is completely symptom free. After a grade 2 concussion, the player is withdrawn from the contest, may play if well after 1 week after passing an exertional provocative test. A patient with a grade 3 brief loss of consciousness is suspended from play for 1 week but may then play if completely well at rest and after exertion. If the loss of consciousness is lasting minutes, that means grade 3B, the athlete must be out for 2 weeks and pass the exertion test. After more than one or a series of concussions, athlete would be returned to play in the following circumstances only. Neurological examination is normal. Sustained a small number of concussions over more time and severity is low. And each time he has had complete recovery. The length of time to complete recovery is short. The neuropsychological evaluation shows no cognitive deficits and the CT or MRI is normal. There are some cases in which an athlete may suffer one or a series of concussions and would never be allowed to return to play. That is, in case of these symptoms, any neurological deficits or symptoms which are persisting. Multiple concussions over a short period of time of higher severity. Recovery was prolonged over several weeks or months. Neuropsychological evaluation revealed cognitive deficits, and MRI and CT showed the presence of brain lesions. If any of these are present, please advise the athlete not to return to play ever. There is something called a graduated return to play, which is a structured, graduated, and supervised rehabilitation model for optimal recovery and safe RTP. It has these particular steps. Initially, no activity and complete rest. When you become asymptomatic, proceed to step 2. Light aerobic exercises like walking or stationary cycling. Next step, sport-specific training. Next step, non-contact training drills. Next step, full contact training after medical clearance. And last, game play. Each step should take a minimum of 1 day. Athlete will move to the next stage only if asymptomatic at any step. If the symptoms reoccur, the athlete will drop back 1 step for 1 day. There are several risks of premature return to play. There is a risk of further injury. There is a risk of developing convulsions. There is a risk of prolongation of the symptoms. You may develop something called chronic traumatic encephalopathy. You will definitely develop mental health issues if you have premature return to play. There is also a syndrome called second impact syndrome. If the individual gets a second concussive blow to the head before he has recovered from the symptoms of a previous concussion, there will be loss of cerebrovascular autoregulation, which causes the brain to swell up due to increased cerebral blood flow. Please note, if the individual has got a concussion, he gets a second concussion before the symptoms of the first have resolved, he will develop something called second impact syndrome. The problem with this condition is the mortality is almost 100%. So that is why we have to be very careful in returning these people to sport after a first concussion. Prevention. Education of all the participants and general public about prevention of head injuries in sport and recreational sport is essential. Treatment and rehabilitation of major head injuries or concussion is poor. So we must emphasize on prevention. Improved education about the detection of concussion, clinical features, assessment techniques, and the principles of safe return to play are mandatory at all levels of sport, whether he is a sportsman, administrator, coach, or doctor. Prevention should be the concern of all those involved in sport. Please teach the players about respect for the opponent and, more importantly, respect for the opponent's long-term health. It should be part of the psychological training in competitive sport. In some sports, you may reduce the concussions by eliminating fighting or improving the safeguards or the safety mechanisms which are there in the sport. Athletes should be ambassadors and supporters of brain injury prevention programs. Take-home message. A concussion can be diagnosed and managed on-field and definitely off the field. You must do a quick neurological examination and use diagnostic tools such as CRT-6. If you are in doubt, use the exertional provocative test because it causes the athlete to exert in a safe and controlled manner. And if there are hidden signs and symptoms of concussion, it can be picked up. Return to play protocol should be started only after full medical clearance. And make sure you follow a graduated return to play protocol. There are several protocols available. Focus on prevention of head injuries and concussion rather than treatment and management. These are the references which I strongly urge you to go through. I thank you for your time, your patient listening, and your attention. We will be glad to respond to any queries or questions or comments. Thank you so much for listening, ladies and gentlemen, and Jai Hind.